All right, I'd like to introduce Dr. Patrick Raue. He's a clinical psychologist and a professor at UW Department of Psychiatry and Behavioral Sciences, Associate Director of Evidence-Based Psychosocial Interventions at the UW Ames Center, and Director of the National Network of Problem-Solving Treatment Clinicians, Trainers, and Researchers. Dr. Raue's clinical expertise includes the identification and management of mental health conditions in medical settings, including primary care and home health care. Dr. Raue conducts NIMH-sponsored research on patient preferences and shared decision-making approaches for depression, the effectiveness of psychotherapy among older adults, and training non-specialists in behavioral interventions. And he's going to talk to us today about Stay Connected, an intervention to promote mental health among isolated older adults. Welcome, Dr. Raue.
Thank you so much for the introduction, and thank you for inviting me to talk to everybody today. I'm really looking forward to it. I'll start by saying I have no conflicts of interest, but will acknowledge support from the National Institute of Mental Health. We have a Alacrity Center P50 here at the University of Washington that has supported some of the research, as well as the Archstone Foundation in California. So my learning objectives for today are, at the end of the talk, to be able to describe how to conduct successful Stay Connected outreach efforts for older adults from diverse communities, describe Stay Connected strategies to teach clients how to reduce depressive symptoms and improve their quality of life, and describe Stay Connected strategies to teach clients how to cope with stress and anxiety. So I have about three different big parts of the talk. The first one is sort of background on social isolation and loneliness and the need for this kind of intervention. Also thinking about where it might fit service setting wise and which providers can use the intervention. Secondly, jumping into kind of a how-to guide on how to use this intervention. And lastly, I'll be presenting the design and results of a small pilot study that we did here in Seattle on the intervention. So I'll start off with some background, and this is an intervention that was initially developed in response to the COVID pandemic, and really acknowledging that, of course, the physical distancing recommendations were necessary to protect all of our health, and particularly the older adults that we serve during the pandemic. Unfortunately, this had a negative impact of kind of creating social isolation and increased rates of loneliness. And a lot of research has shown a variety of negative health and mental health outcomes related to perceived loneliness among older adults, and puts older adults at risk for increased mortality along the lines of what smoking can do. So really some striking findings about the negative impacts of loneliness. So our challenge as providers who serve older adults are thinking about, and of course these physical distancing practices are still relevant and will continue to be relevant to some extent, while at the same time promoting social connections and addressing mental health needs of the clients that we do serve. So a little bit about sort of the development at the start of the pandemic. We had sort of several lines of synergistic ways that we developed and started to roll this intervention out. The first was we were doing some Archstone funded work. Principal investigator was Jürgen Unitzer, our chair in the Department of Psychiatry, that supported a number of partnerships in California between primary care clinics who had some sort of integrated mental health care and a variety of community-based organizations. They could have been social service organizations or faith-based organizations or peer organizations serving older adults. And we were really oriented to how could we facilitate these partnerships and address the depression that their older adults were experiencing. When COVID hit, we kind of continued the work, but these organizations all reached out for assistance in doing outreach to older adults who may not have had mental health needs at level of psychiatric diagnoses, but it's a way to keep them engaged and kind of promote their mental health. So that was part of the impetus for developing Stay Connected. Along the same time, when our area agency on aging in King County heard about this, they devoted some funds to support implementation of Stay Connected in a variety of very diverse aging care organizations, serving not only English speaking, but also Spanish speaking, Chinese and Indian older adult communities. Also, at the same time, we received some support from NIMH to do some pilot work to first assess mental health need in Seattle area senior centers and public housing facilities, and kind of co-develop an intervention that their staff could use. So we had a lot of different synergistic, origins of Stay Connected. So I'll start with some of the surveys that we conducted, very small scale in about 4 different senior public housing communities, where we kind of surveyed mental health needs and the broader impact of the COVID pandemic. We found that, based on our screening instruments, about 20% of older adults met criteria for some sort of psychiatric diagnosis, major depression or anxiety disorder. In addition, an additional 31% fell in more of that sub-threshold region, that they were in some sort of distress, either reporting elevated loneliness or some sort of milder forms of depressive or anxiety symptoms. So all told, this is a pretty high percentage of older adults in need. In addition, all of them reported, not surprisingly, that that they had radical restrictions in their socialization opportunities, and reported pretty profound isolation, and a number of other negative consequences, like obtaining necessary food, obtaining medical care that they needed, or the medications that they needed. Continuing on with background, we know that certainly nationally, that mental health of older adults is really poorly addressed. That under 20% of older adults with mental health need receive sort of what are considered minimally adequate kinds of treatment. For example, psychotherapy or antidepressant medication at an appropriate dose. And these gaps in access to care are particularly evident for older adults from various racial and ethnic minority groups. A lot of different reasons for this, at the client level or patient level, kind of like acceptance of need for treatment, and stigma can interfere with getting care. But there are a lot of also access barriers related to their, insufficient number of providers who specialize or are willing to see older adults with mental health issues, and some sort of systemic kinds of issues as far as, average amount of time that, patients have, to kind of speak to their providers about mental health issues and what's available to them. Some of the proposed solutions come from some national guidelines. This is an Institute of Medicine report, and there's some SAMHSA reports as well about what can we do to increase access and kind of narrow this gap in access to care. And one of those ideas are, integrating mental health care into non-specialty settings. So many of you know and work in settings, medical settings or primary care, that integrate mental health, more seamlessly into primary care. And that's just a great model for thinking about other creative ways we can do that. So I think a lot about aging community settings, whether it's senior centers or public housing. And even though there is very little history of mental health screening, assessment, or care, what are some creative or innovative ways that we can integrate mental health into those settings as well? Another proposed solution is not to just rely on psychiatrists, psychologists, social workers, trained clinicians. And as I mentioned before, there are very few clinicians who specialize in treating older adults. So some creative solutions are, well, what can we safely and effectively train staff, people who are, maybe non-licensed clinicians or non-clinicians or lay health or providers or even peers to do, again, safely and effectively. Again, this is all important background for our development of Stay Connected. And to speak a little bit more about lay health providers or training non-specialists, to be specific, these would be individuals with no formal background or training in mental health care to deliver brief, what some have called low intensity psychological treatments. And that just means simplified versions of evidence-based behavioral strategies that we know are effective from the psychotherapy literature, but can maybe be adapted and simplified to non-specialists. Originally, didn't start with mental health, but started with kind of global HIV and AIDS screening and treatment, the need and the creativity of what we could train lay health providers to do. Later extended to mental health care, in particular depression, in a variety of first, low and middle income countries. And some researchers, myself and others, have kind of found some applicability in the US and other countries. So some of the providers that have been looked at are community health workers, promotoras, serving Spanish-speaking communities, and within primary care, folks like behavioral health aid or other specialty settings potentially. A little background, I know a lot of folks are in primary care settings, and I think this intervention has applicability there too, but just to speak about aging care settings and talk a little bit about what senior centers are. And these are centers funded by the Older Americans Act, and there are over 10,000 senior centers throughout the United States. The mission is really to serve predominantly mid and low income older adults and to keep them living independently in their homes for as long as possible. Senior centers offer more than bingo and congregate meals, but they do offer a variety of other nutritional services, recreational activities, social activities, case assistance often provided by a social worker who is not necessarily trained to provide psychotherapy, but to provide social service case assistance, and health promotional activities. They may have a nurse coming in every now and then to do blood pressure screening or foot care or things like that, but no formal mental health care traditionally. New York City, by the way, is an exception. They're kind of rolling out some innovative mental health screening and social work kind of services within some of their centers. Folks in senior public housing are a little bit different. These can be overlapping populations, but distinct in some ways. These are residents who receive subsidized rental housing and rental assistance if they have low income. And there are some services attached to these housing facilities. There could be some health promotion services, job training, placement, computer access, and some activities. Not to the extent of senior centers, but they often offer some of these services. What both of these organizations have in common is that since COVID, particularly in the height of COVID, a lot of their staff were making kind of routine wellness calls. It could have been weekly, it could have been monthly, whatever schedule. They were trying to do some outreach because anything in person regarding these programs and services was not being offered anymore. But they were doing basically unstructured wellness calls to kind of see how things were going and how they could be helpful. That sets the stage for what we thought were great opportunities for Stay Connected. So an overview before jumping into the how-to of it. is that this is a way to structure some of those unstructured wellness calls that's the staff were doing, including, by the way, some of the primary care staff that we worked with in the Archstone funded study or implementation project. So to provide support and simplified evidence-based strategies to older adult clients who were experiencing greater isolation due to COVID. So eligibility, community dwelling older adults or primary care patients who reported kind of any level of anxiety, mild anxiety, depression, or loneliness at the beginning related to COVID. But a side note, I mean, even if even if COVID resolves, isolation and loneliness among older adults is still going to be a problem, of course, right? Because there's so many different reasons for that, increasing medical illness and disability and issues with mobility and dwindling social networks and loss and things like that. So loneliness and the need for this intervention is still relevant, even if it's not directly related to COVID. Staying with our overview, some of our strategies involve first engaging clients and talking with us for this kind of intervention, doing a needs assessment, and I'll go over what that means, doing a tailored assessment to see what folks are struggling with. First, of course, addressing any urgent social service needs, then turning on to teaching some specific skills, and they could be, if appropriate, related to stress and anxiety management and or some behavioral activation strategies to reduce depressive symptoms and improve overall quality of life. I'm going to go into a lot more detail on all of these. A note on, it was new at the time when we first rolled this out as far as doing things remotely. So we spent a lot of time talking about how this can be done either via, video conferencing or via telephone, and just acknowledging that if people aren't coming to our offices, privacy can be more challenging for clients when you can't necessarily see them or their living environment. So it's helpful to be structured and be organized ahead of time, and also to set an agenda like we do with any good behavioral intervention, kind of setting an agenda up front that makes sure that we let clients know what we think would be helpful to cover and hear their concerns, and make sure that we come up with a mutually agree upon set of things that we want to talk about. As you'll see, Stay Connected involves some psychoeducational materials and in-session worksheets that can be really helpful. And so if we're not in person and we can't share our screen, mailing the old-fashioned way, or emailing ahead of time, or right after we first speak with them and find out they're eligible for this kind of intervention, can be really helpful. For video conferencing, we found ways to create these fillable forms that we can show on the screen and kind of type along into those forms too, as a way to be really concrete about going through the intervention and what the action plan is that the client sets for themselves. We found it's really helpful to have a checklist or a cheat sheet for providers to remind them the things that they should be covering in the order. So the introduction, engaging people into the intervention, review, prioritizing the urgent social service needs first, doing the needs assessment, doing some screening for depression, anxiety, and loneliness. As applicable, providing a research sheet that we'll go over, teach self-management strategies as appropriate, and then talk about the need and the client's interest in setting up another contact with us to move forward on their successes or challenges. So, this was really relevant to, folks who, hadn't seen their clients or patients in a while, and we're doing these kind of cold call outreach calls, these wellness checks, helpful to, reintroduce yourself and what your role is, and that, to destigmatize this, we do stick with this being like a health and wellness check to see how they're doing, rather than this is a call about depression or this is a call about loneliness, which can be, of course, very off-putting. And some open-ended questions first about any struggles related to COVID, and how they're doing since then. And keeping an ear out to concerns about social service issues and getting the services that they need, particularly regarding housing and food and medication and making medical appointments. Keeping an ear out for any reports of feeling lonely or any kind of emotional distress. And I'm going to talk about also using some screening as well. But and again, and you'll see this language in a way to we're not offering a psychotherapy here. We're offering ongoing contact and support and some strategies that can be helpful. So we kind of frame it as, we actually have some, whether we're working in primary care or a senior center or public housing, we have some resources that might be helpful for you this time. Would it be okay if we spend some time talking about what might be helpful for you to address and then mention what their concerns are? If they don't, a little probing about why it doesn't interest them, and would it be okay if we, reach back in a couple of weeks to check to see how they're doing? The first step then, as far as an intervention, would be to kind of address or, refer or, assemble some resources that are addressing unmet social service needs. This intervention doesn't go into the nuts and bolts of really good case management, but a lot of folks who are doing this intervention, whether they be social workers or nurses or other staff, should be, if it's part of their scope of practice, should be, kind of tuned into what those resources are. So then we move on to the screening and assessment of, mental health concerns. We definitely recommend for this program, and many of you, particularly if you work in primary care, are at least familiar with the PHQ-9 to pick up elevated depressive symptoms. You may be familiar with the GAD-7 for anxiety symptoms. And there's a really brief 3-item scale that really picks up loneliness in a very non-stigmatizing way. It doesn't even use the word lonely in it. And if we see elevated scores on one or all of those, folks may be eligible for ongoing contact for this kind of intervention. And it can really, in some ways, as you're listening, you're hearing this is sort of a menu-driven intervention, that not every patient or client needs every single strategy that we have, but based on the results of these scores, it can give us a useful guidelines for what strategies might be most helpful for which particular client or patient. And again, these scales have the added benefit of if there are scores above certain thresholds, they may need more than stay connected, and we may try to facilitate more formal mental health evaluation and care, like medication and or psychotherapy. Many of you are familiar with this PHQ-9, just wanted to show it on the screen. Originally developed as a paper and pencil measure. For example, you could fill out in a waiting room. However, it can certainly be administered interview style. You can read these items off and get, a response from clients about how frequently, whether these are issues for them, and if so, how frequently or intense they are. And all of these 9 symptoms correspond to the 9 symptoms in DSM-5 that help us make a diagnosis of major depression or other mood disorders. Here's an example of how it might be scored. If folks are endorsing little interest or pleasure more than half the days, we circle a 2, feeling down a 2, trouble falling asleep, several days as a 1. And we add those up. The total range is from 0 to 27 maximum. This particular example, we get a total score of 16. Here are, just to note that the PHQ is a screening instrument and not an actual diagnosis. You should be doing, or a clinician should be doing ideally a follow-up clinical interview to determine an exact diagnosis. But we call it a provisional diagnosis because research does support these cutoffs as corresponding to diagnoses in a variety of research studies. It also provides information about how severe the depression is. A good indicator of possible eligibility for Stay Connected would be those in the mild depression area, scoring 5 to 9, and maybe even higher as well. a good indicator for the value of further evaluation and possible formal mental health care over and above stay connected would be scores 10 or higher. Rule of thumb. You all, particularly if you work in primary care, probably have pretty well-developed suicide screening and management protocols. If you work in aging care settings, your organization may not have as well-developed a protocol. So this is just suggested extra set of questions if people do endorse item 9 on the PHQ that lets us know if people are experiencing some level of suicidal ideation, but doesn't give us too much information about level of risk. Is it passive ideation? Is it active ideation? Or are people really at very high risk and have a specific detailed plan or intention to harm themselves in the near future where that would be a clinical emergency? These are just some suggested additional questions to ask to get a sense of risk. Again, not formally part of Stay Connected, but this should be the backdrop for you feeling confident in assessing risk level. And then you would want to follow whatever your organization's risk level is, depending on what clients or patients endorse. If a non-clinical staff member or lay health person is doing these screens and intervention, then this would be appropriate to certainly alert the rest of the team and clinicians on the team so they can do a more full risk assessment and get a plan in place. I won't go through this, but these are just some suggested protocol for you. Okay, moving on to some of you may know about the GAD-7, 7 symptoms of anxiety that correspond, again, not the same as making an anxiety disorder diagnosis, but will indicate certain level of severity. The same answer stems as far as not at all sure, several days, over half the days or nearly every day. And this is the score, how you score it. Again, a good indicator for possible eligibility for Stay Connected would be certainly those with 5 or above, 5 to 9. Mild anxiety could benefit, potentially higher. If 10 or higher is that metric, again, like the PHQ, that could indicate the need for further evaluation and possible formal mental health care. Here's that relatively non-stigmatizing way to ask about loneliness. It's the UCLA loneliness scale. How often do you feel you lack companionship? It's either hardly ever, some of the time, or often. Question 2 and 3, you add those numbers up together. Total scores of 6 or higher could indicate significant loneliness, and again, the benefits of using Stay Connected for folks who endorse loneliness here. A word about why the value of first using these validated screeners and also using them over time, just like you might do in collaborative care or integrated care and primary care for formal mental health issues. It can first guide your decision-making about which Stay Connected strategies would be most helpful to use. And they're an objective way to track response to the Stay Connected program, that we would expect that as people engage in the program and try some things out in the real world and learn some new skills, that we would hope that some of those scores would go down, but it's an objective way to see that. It can also be used to empower clients and really as a psychoeducation tool to enhance their understanding of the stresses they're experiencing and the impact on their mental health, as well as the impact of their successes and efforts. So if they find more successes in reaching out to other people and feeling more connected, for example, and doing more valued and rewarding activities, and they see reductions in their PHQ or reductions on that UCLA score, they're going to feel a little bit more empowered, like there is actually something that I can do and some strategies I can use to feel better about myself and my situation. If you don't use those formal scales, you can certainly assess depression, anxiety, and loneliness a little bit more or informally, but I'm sort of making a pitch on the value of using those screening forms. So let's say we get a sense of, people are eligible, and what level, how they're distressed and by what. We can assemble for them a resource sheet, and these are it can be tailored to them and what's of interest to them. But here's a variety of different things that we might be looking at. Some good website material from SAMHSA and other places about how we can all manage stress associated with COVID. The VA has for those older adults who are tech savvy and use the internet and maybe have iPhones and can download apps. Of course, not everyone does or is tech savvy. The VA has come out with a lot of good and free apps to kind of help manage depression and anxiety, and this mindfulness coach is a good one. Other tips for well-being, there's also a friendship line that's available nationwide that older adults can kind of call into just for support. It's not a crisis line, but it's sort of a supportive listening. Some senior centers offer these really interesting intergenerational programs. Finney Center, Greenwood Center in Seattle, I believe is still facilitating a pen pal project where they link up older adults to school-age kids and do the old-fashioned pen pal, which older adults who enrolled really seem to appreciate, as well as suicide prevention lifeline if that's relevant for older adults. Okay, I'm going to talk about if folks are endorsing stress, elevated anxiety symptoms on the GAD-7, for example. Here are some specific strategies that can be helpful. And first of all, some just sort of general kind of guidelines and strategies, and talk about how somebody can take care of themselves if this is relevant as far as how they're eating and drinking and exercising and taking their medications. Limiting news is a very reasonable strategy to support. Many of us feel maybe socially and politically obligated and a good way to keep up on the news and find out what's going on. But at the same time, there is a lot of negative events out there and spins. And so it's okay to take a break from the news, and we can talk to our older adult clients about that and how to do that. We can support what techniques that they found successful in the past to manage their stress and reduce their anxiety. And if they haven't heard of some of these options, but they're willing to talk to you about it, you can kind of pursue that further. I have an example on the next page that I'm going to go through on diaphragmatic breathing. Planning their day and keeping a structure to their day, including not just responsibilities, but also pleasant and rewarding activities. Going to talk more about that later. And the value of getting outside and being active and just moving one's body around, and how that can be a stress reliever. Here's one example that some older adults with anxiety may respond to. We call it deep breathing or diaphragmatic breathing, and is really appropriate for those folks who have a lot of those physiological symptoms or signs of anxiety. So rapid heart rate, rapid or shallow breathing or hyperventilating, feeling lightheaded or dizzy, feeling some of those gastrointestinal symptoms like butterflies in the stomach. And so we can actually, most people have heard about the value of, counting to 10 and, focusing on the breathing, but it's actually a skill that can be easier said than done. So there's value in demonstrating it and practicing it with clients and encouraging them not just to do it with us on a phone call or in the Zoom session, but to practice on a daily basis, because it's like It's like a muscle. It's like going to the gym. We have to practice it, particularly at times when we're not feeling particularly anxious or stressed. So we kind of get a more mastery and we feel better about it. And then it becomes something that we can use even in situations that we feel stressed by, and we may kind of, forget to use our stress management coping strategies. So it basically involves, and here's a really brief YouTube clip that you can actually show or send to clients too that actually demonstrates it. You can also demonstrate it live in session. This involves diaphragmatic breathing. You can say is a technique that actors often use to kind of get control of their breathing and to be able to say their lines or to be able to sing effectively. And we start by taking slow, controlled breaths into the diaphragm. And we can put one hand on our chest and one hand on our stomach, and we'll know it's working if we see the hand on our stomach kind of moving forward and not the hand on our chest. The key is to do that very slowly. Inhale slowly for about 3 seconds, exhale slowly at the same rate. And again, can take a lot of practice. So really simple technique, but a lot of folks, not just older adults, like to use this and to practice it. Okay, I'm going to go over some of these BA strategies and then pause for to answer some questions before moving on. Behavioral activation strategies for both depressive symptoms as well as perceived loneliness. What are these strategies? They're evidence that comes from actual formal psychotherapy that clinicians can use, but the strategies themselves can be simplified, as I'm going to present here, such that staff members, lay health providers, peers can potentially use as well. Best practice strategies for reducing depression. One of the most powerful techniques that we can teach our patients or clients who are struggling with depression. It doesn't just involve pleasant activities, but it also kind of looks at important things that our clients are avoiding, what they're withdrawing from, and lack of routine or being inactive, particularly in comparison to usual functioning. It's a pretty structured approach where we work with folks to plan things proactively on a weekly basis, where we come up with a plan and help them set some SMART goals, specific, measurable, achievable, etc. Pretty brief, pretty easy to use. And the idea is it helps folks who are struggling with depression improve their mood by engaging in activities that are important to them and they find rewarding. Here's the conceptual model. It's pretty simple. And here's how we would describe it to an older adult too. Regardless of what depression is due to, or these increased sadness or increased feelings of no motivation anymore, I'm not myself, regardless of what that's due to, what happens is that when we feel bad and not motivated, it's really natural to do less. We are less physically active, we do less hobbies, we keep in touch with family and friends less, we stick to our routines less, so we avoid things that maybe feel like they take effort to do or our responsibilities. Unfortunately, when that happens, it tends to make us feel worse. Emotionally, we feel worse, less motivation, even more physically tired. And that can create this vicious cycle that maintains those bad feelings, those bad emotional feelings. The good news is that we can work together on some of these really powerful strategies to help you get back to your usual self. We find we do this really slowly, really gradually by targeting something that's important to you that maybe you want to do an experiment and pick up again slowly. So doing one more thing, little thing, ideally something new every day over and above your normal routine, even if it's only for 5 or 10 minutes to start. Could be going out and taking a walk that we haven't done in a while. It could be making a phone call to a family member that we haven't reached out into a while. It could be religious or spiritual activities. It could be anything. And we find that when we do things that are important to us, we usually find we get a mood boost. We feel a little bit better, a little more motivated, a little bit more energy, and that gives us maybe more energy to do a little bit more and tackle more. One walk, one phone call doesn't cure depression or these bad feelings, but it's a great start, and it gets us to gradually unwinding that vicious cycle and back to our usual selves. This is how we frame the rationale to folks for how this could be helpful to them. These are some forms. I forgot to mention that included in your materials, not only the PowerPoint, but you'll have access to the full Stay Connected manual. So you'll have these materials and patient education materials. This first one describes that vicious cycle, and you can give that to patients or clients. The second one, this list of pleasant and rewarding activities. I could do a whole talk about how to do this, but in the interest of time, I can only introduce it for you now. This means a form that helps you work with clients to help them brainstorm things from any domain: social, physical, hobby, recreational, spiritual, religious, that could be mood boosters for them. They might not be doing it now, but they used to do it before they got depressed, or things that they'd always like to try. It's creating a bank of activities that are important to them. You're not asking them to commit at all. You're getting to know them and getting them to kind of have fun and brainstorm. You also helped them to get into tune into how difficult each of these activities are, given how they're feeling right now, both physically and emotionally. Thinking about easy, medium, and hard. Because again, remember, the spirit of behavioral activation is we start slow. We don't set somebody up for failure by, encouraging them to try the hard things immediately. We keep it on the list. We acknowledge it's important, but we start slow. We tend to start with maybe the easier activities. This last form is that proactive weekly scheduling. Again, we frame it as now, I didn't ask you to commit to anything when we were developing this bank, but would you be willing to work with me? Think about the upcoming week and a couple of things that you could do in the next week to try as experiments to see if they're good mood boosters for you. And here's where you do the SMART goal. You say, I'm going to ask you a few questions, and I might get super specific about what you're going to do and when and for how long, anybody else involved. And the reason I'm asking so many questions is we find that the more detail you put down, the more likely it is that you'll actually get success at that. And then we encourage folks to actually use this form as a cue and a reminder to follow through and to take a few notes through the week. Was this a good mood booster? Were you satisfied with your efforts? If something didn't go well, take a little note about what got in the way, was the obstacle, so we can problem solve later and get you success next time. Okay, I'm almost going to pause for questions, but this is all in the context of your very first visit. It sounds like a lot, but it could potentially all fit in a half an hour. Again, engaging, doing the screening for mental health issues, making some decisions about what are the most appropriate strategies, and jumping in and trying some of those strategies out. Again, you don't have to do everything in session one, but you could get some of those started. And that some folks don't need ongoing contact, and they're not really in a lot of distress, and maybe one call is all they need. But some folks are struggling and would really appreciate your offering of some ongoing contact and an offer to speak with them next week to debrief how their experiences went in the prior week, and to look ahead to the upcoming week. So it's very much like a behavioral intervention that clinicians might be doing as far as that ongoing contact. I mentioned before the value of agenda setting at the beginning of every meeting, and really important. And here's a suggested script that you could use, and you can certainly, of course, tailor it. So again, the whole idea is that we're building on what were unstructured wellness calls. We're making them a bit more structured and evidence-based. Part of that is setting the agenda. So let's start today. Hi, Mrs. Smith. Nice to hear from you. Let's start today's call by maybe setting an agenda or plan for what we want to accomplish in the next half hour. Want to make sure that I check in with you to see if there are any urgent concerns that you have about, food or medical appointments, things like that. And then I'd like to check in on your mood and anxiety levels to see if any changes from how you were feeling from the week before. And I'm really curious to see about, you had some goals that you had from last week. I'd love to check in on how that went and, any successes or challenges. And we can save, quite a bit of time to looking ahead to this coming week to check in on new goals and things you want to practice. Anything else that you'd like to add to that agenda, make sure we cover today? An example of a good agenda to kind of set the stage and stay on track for these remote calls. Another cheat sheet for you, very similar to meeting number one, and so on. And this could go on for, you'll be making judgments along with your clients and patients about how frequently and often to meet. Before getting into some practice, I wanted to pause there and just giving you a lot of information and details about both the background and the intervention itself, to see if folks have questions about any of this.
So I don't see a lot of questions. I don't see any questions at this point, but I'm going to post into the chat box the link to where the PDF handout is posted, which, just to let you all know, at the end of the slides is the manual that he was talking about from the Stay Connected program. There is a question that says, is Stay Connected still active today? If yes, how have you built the business case to continue this sort of non-billable service? Or are you billing for telephonic visits? Or is billing done through chronic care management for Medicare FFS?
Yeah, all great questions. So I am in process of submitting a formal kind of a research effectiveness study to the National Institute of Mental Health that would allow us to continue partnering with Seattle area centers and aging care facilities to continue to develop the evidence base, which I'll speak about a little bit in the pilot study to come. Seeking other sources of funding. Our own, again, Aging and Disability Services is that funded an earlier implementation project has reached out and is potentially interested in continuing to offer this from an implementation perspective. So the money so far has come from Archstone Foundation, the City of Seattle, funneled through Aging and Disability Services, as well as NIMH. So those are the funding streams. That we haven't gotten to the point to think of business case, or reimbursement structures in any way. So I'd be interested in you all brainstorming with me about what needs to happen there. I mean, part of it is I'm doing my diligence to continue to develop. These are all evidence-based strategies, but the intervention model and package, we're still needing to kind of develop that evidence base to before like trying to roll it out on a broader scale.
And I think most of you know this, but for those of you outside of Seattle, Aging and Disability Services is the Seattle King County AAA. So those of you who are connecting with AAAs might explore this possibility with them. Cindy said you mentioned that only 20% of older adults get minimal treatment. Is that 20% of all older adults or 20% of those in need of treatment?
It's the latter. Among those with clinically significant mental health issues like depression and anxiety, of those that have been identified in need, only 20% of those get adequate treatment, minimally adequate treatment. So it's a real gap. It's a real problem. Yeah.
It's a current concern.
Yeah.
And then just a comment that this seems well done. It looks easy to implement. And that's all the questions I see.
Great. Appreciate that. All right, going to keep trying to get you more involved here and thinking on 3 practice scenarios that I have. And I'm just going to present just super brief scenarios and just type in the chat what stay connected strategies might be helpful. So let's say we have a 70-year-old woman living with her husband in senior public housing. you talk to her, she says, I'm feeling upset, I'm feeling pretty lonely. Particularly at the early stage of COVID, group activities were no longer available. And in some cases, that's, senior centers, by the way, are just opening up and they're not really fully open, and they're still offering some remote kinds of services. And at the time, no visitors were even allowed to her in her public housing. So, things aren't quite as severe now, but it's this is somebody who we did, a typical person that we did, hear about and try to serve. So be interested, just, I won't call on anybody individually, of course, but if you're to think about the range of stay connected strategies that we were talking about, what do you think would be most relevant to what would be the best ways for us to help her from like a stay connected perspective, as far as think about any urgent needs, think about those resources that we might connect her to, think about if, we talked about stress and anxiety management strategies, and we talked about our behavioral activation strategies. What strategies do you think would be helpful? What else do you want to probe or know about her to, be more confident in that? Feel free to just type in anything. And again, we won't call on any of you, but just I just would like to stimulate your thinking, and then I'll give my thoughts. This gives me a break from talking, so please.
I have a feeling everyone's deep in thought.
That's okay. We'll keep thinking. And I would say, certainly her loneliness would be, key here as far as something to, think about addressing. And everything that I was, kind of saying about, ask her what she used to do. Absolutely. You really want to know, what was her functioning and what was her activity level, before all of this. And, what kind of contact she had with friends and family. Absolutely. So those are, some additional probes we'd want to ask her. We'd certainly want to ask her what she means by upset and get a little bit more information. But given, this report of lonely, all of those behavioral activation strategies could be really powerful for her. So we can't necessarily change things for her or offer services that don't exist, right? But we can BA is often about it, helping the client or patient brainstorm things that they're able to do and that they have access to do, and help her brainstorm what are the things that you used to do, could do now that would make you feel more connected to other people in light of all of these restrictions, even if you can't have visitors, for example. Maybe second best to having in-person contact, but sometimes when we get feeling lonely and depressed, we think all or none. Well, it's got to be this way or not. We can help somebody think about other ways to feel connected to other people. Again, whether this is FaceTime or writing letters or sending cards or, phone calls and things like that. We don't have to decide that for her. Our job from a stay connected perspective is to facilitate her own brainstorming.
And there have been some suggestions like FaceTime or some sort of pen pal, or a friendship line, or just creating some sort of a activation plan for enjoyable activities like knitting or sewing or reading.
Excellent.
Yeah.
Excellent. And again, the key, we think about what resources or referrals we offer versus what we facilitate. So that's really important. Like if there are resources that a client doesn't know about, for example, a pen pal program, from a stay connected perspective, it's certainly willing for us to float that as an option. Part of the power, though, we should keep in mind of this approach is it's, even though we may be tempted to give the client, here are 5 things you can do, I encourage you to do it. Natural response of everybody is to say thanks, I'll think about it, or react to that. It's much more powerful from evidence-based behavioral perspective to ask questions and facilitate the client's own brainstorming. What did you used to do? What did you enjoy doing? How did you stay connected before? What would you recommend to a friend in a similar situation who is isolated and couldn't have visitors, to feel connected to other people. Getting folks to do their own brainstorming is a lot more powerful than, coming up with suggestions for them. So that's just an important thing to keep in mind. But great ideas. And whether she can go outside is, something we want to know about and ask about. All right, second of three cases. Think of a 64-year-old man working in the service. He's actively working in the service industry, currently out of work. Reports high anxiety about his finances and his future employment opportunities, and at periods of, kind of feeling totally overwhelmed and just kind of shutting down and not doing anything. Similarly, I'll encourage you to think about what stay connected strategies might be helpful. What else what else might we want to know about him and ask about? What strategies, either social service, more urgent needs, are anxiety management strategies helpful? If so, which ones? Are behavioral activation strategies relevant to him? If so, what would that look like? I will pause my talking just to give you a chance to think about that and, type in any ideas that you have. Well, as you think in chat, certainly there could be urgent needs. We want to find out more about, about his finances and what's going on there, and whether there are, resources that we could provide to help in that way. He presents with, lots, realistic worry, but also some excessive worry, right? And if he's reporting periods of being overwhelmed and shutting down, that indicates some excessive worry and anxiety. And what might have contributed to him feeling overwhelmed above and beyond. It could be more than just finances. So we want to know that and probe that, absolutely. And we should think about the relevance of those anxiety management strategies, not only to help connect him resources and problem solve something that can be solved, like finances and employment opportunities, but how to manage these periods of shutting down, and maybe some of those anxiety management things like relaxation training or imagery or realistic thoughts or deep breathing could be a skill that he might be willing to learn and kind of practice to get through those shutdown periods. And if it's asking about his daily needs being met, connecting to relevant services and support groups is actually a great possibility too. We should keep that in mind about the existence of remote support groups as well. And mindfulness, super consistent with one of those anxiety management strategies that we spoke about. Great.
Cindy also brings up a good point about paying attention to whether what we suggest might even add to him feeling overwhelmed, and so making some of those connections to like AAAs that can help point him to resources and take some of that worry off, his
Yep.
mind would be helpful.
Agreed. Great. And we could also probe a little bit more in depressed mood and loneliness too, and to see whether the behavioral activation strategies might be helpful too. But those are some great directions. Lastly, 68-year-old woman, sole caretaker of 2 grandkids, reports lack of motivation to take care of the kids, lack of motivation to do basic household tasks, lack of energy, and significantly reduced physical activity. What stay connected strategies might we be thinking about, or what more do we want to probe and know about? Asking when these symptoms begin. Yeah, that's a definitely relevant question. And I think a little bit, we could probe the extent of the difficulty she's reporting with managing, taking care of the kids and, the household tasks and how severe that is and whether she needs extra support and whether there are resources there. Asking if reduced physical activity has led to any other physical problems or made physical health worse. Absolutely, because the reduction of physical activity could be a sign or a symptom of depression, but it could also be creating other negative consequences like reducing physical health. Absolutely. So some of those strategies that we kind of work on could be around managing physical health problems and managing physical health. That's kind of that we can fold that in the behavioral activation domain. So clearly, behavioral activation strategies should be really helpful for her, given her report of some significant depressive symptoms. This lack of motivation and energy are really consistent with the depression picture. Again, it might be severe enough that she needs formal mental health, but she could also you could start with stay connected and see if that kind of meets some of the goals she has and offers her some relief of these symptoms. So again, remember that behavioral activation is about slowly picking up some of those activities that are hard. Depression, by definition, robs us of her energy and her motivation. So it's not easy, but behavioral activation is tailor-made for these symptoms because it helps people start really slowly on things that are important to them. And it could be around gradually picking up physical activity, finding ways to feel like she's taking care of the kids and the household tasks, but starting slow, building her confidence, and then ramping that up a bit more. You can keep sharing comments about that particular case scenario, but also pause for like broader and grief issues could be relevant for her as well. Pause for just other discussion points or questions about, not only the scenario, but the program itself.
Patrick, I have a question, which is it consistent with the Stay Connected program and almost behavioral activation to identify opportunities for respite and things to do during that respite from some of the other things that are bringing a person or making a person feel overwhelmed?
Definitely. When you say respite, you mean more like formal resources?
Yeah, formal resources or someone who can take the grandkids for a day or two and she could make plans to do
Totally
something else she
consistent.
enjoys.
Totally consistent. And that I can't claim that's like it's not a new intervention that Stay Connected originated, but it acknowledges that though any resource, respite or otherwise, that we can connect clients to are totally part of the Stay Connected agenda, like really addressing all of those needs. Some of them are connection to resources, some of Stay Connected and a big part of Stay Connected are teaching self-management skills, but we use whatever is appropriate. Other observations or questions so far? Barb, I'm mindful of that I should only be taking another 5 or so minutes to present the rest and save more time for questions. So, oh yeah, well, great point. I did those scenario were relatively young folks. So absolutely there no reason that these should develop some cases for the old, absolutely relevant for folks in their 80s and 90s as well. But these strategies are all about meeting patients where they are and where their functioning is. I mean, we can do an exercise where we can even think about somebody who's totally homebound or even more extremely bedbound and Not everyone who's bedbound automatically is depressed, right? It's not, it would be understandable if somebody did get depressed, but it's not an inevitable outcome. So we can do an exercise where we brainstorm all the different things that you can do if you're bedbound to be active and to do rewarding things. Socially, what can be done physically in the bed, what, just think about that radically restricted kind of mobility and ADLs. But what somebody can do from a behavioral activation perspective is a valuable exercise.
So we can continue to post questions in the chat, but feel free to move on and I'll just track them into the end.
Okay. And then apologies that I'm going to be going through the rest of this pilot study relatively quickly in the interest of time, but know that you have these slides available if you're interested, and I'm working on a publication for a journal right now. So, and feel free to reach out, of course, with any questions for me. So we did a relatively small pilot randomized control trial to determine whether this stay-connected intervention as delivered by non-clinical staff of a few senior living communities compared to kind of the usual care, the sites that we're doing just the unstructured wellness calls. Really looking at, could this be feasibly delivered remotely to those clients who were eligible, and had a clinical impact that we measured by the behavioral activation scale that looks at increases in rewarding activities, increases in perceived emotional support, decreases in depression symptoms, and decreases in anxiety symptoms. So we worked with 5 staff, a total of 40 eligible clients who attended or resided in these public housing facilities, 60 or older. And again, we had a really wide net as far as inclusion of reports of either loneliness or depressive symptoms and or anxiety symptoms. So a wide net. Couldn't have had a history of mania or psychosis, current substance abuse, active suicidal ideation, and they didn't have evidence of dementia. They could have had mild cognitive impairment though. Training and supervision, we do pretty intensive, rigorous training of these non-clinical staff, 4 2-hour group trainings where we go over the manual and practice. Partly what our group did today, didactic manual review, and I do demonstrations and we do some role play of what it's actually like to deliver this, along with weekly supervision. These are the measures that I actually spoke about, and we administered these at baseline in week 4 and week 9. Brief description of clients, the average age of 75. Majority were white, and the majority were female. Small study. 36 of our 40 clients did complete all 9 sessions. So that was actually great news that when we offered this intervention, that the great majority actually completed it, as well as our research follow-up assessments. 3 of our adults, we lost to follow-up. We just couldn't track them down. And 1 just dropped out that felt that the rest of the program was not for them. This is our results slide, and don't worry too much about the numbers. And this, we weren't expecting to see statistically significant differences because of the small sample size, but we see that this is our behavioral activation scale, that we see it actually increasing is good. So the folks in the Stay Connected intervention did report that they were doing more pleasant, rewarding activities and avoiding and withdrawing less than they were before. Those in usual care at 4 weeks, they did see a bump there, but then they were down to their normal lower levels at 9 week. Again, we didn't care about statistical significance here. We're looking at kind of trends and what are we seeing. Emotional support seemed to kind of improve a little bit, not a lot for either group. The biggest changes that we saw were in these depression scores, that both groups significantly dropped their scores at 4 weeks, but then the Stay Connected continued to maintain and drop a bit at 9 week, whereas the usual care folks popped up again, unfortunately, at 9 weeks. And GAD-7, we didn't see a lot of differences there. So Wanted to give you a flavor of this is a report from the staff at an organization serving the Indian and Indian American community in Seattle. I think the most challenging part was the lack of education about anxiety and depression, and clients even accepting that feeling lonely and having anxiety are issues to talk about, and believing that there may be strategies which can help deal with these issues. The other challenge was to get them to talk about the loneliness, anxiety that they were feeling, especially for the senior clients living with their children or grandchildren. They feel that feeling lonely while living with their family members would be interpreted that they're blaming their family members for their loneliness. Really interesting kind of cultural, consistent cultural observations that we were getting here. Another challenge was clients feeling distrustful of us due to the virtual format, and them being worried about the fact whether their information was being protected. We address these challenges by constantly reassuring and normalizing these issues, being very patient listeners and trying to make them comfortable sharing their emotions with us. All right, I think I got a couple more slides. So we have some data, very preliminary, but support the feasibility, preliminary impact of this intervention. Clients in the Stay Connected group showed improvements in their activity level, a bit of their improvement in their perceived emotional support and mental health symptoms, particularly depression symptoms, and being greater than in usual care. And Stay Connected, we feel, has the potential to reduce loneliness and prevent the development of more severe mental health conditions among a variety of community dwelling older adults. Again, want to acknowledge the limitations of small pilot study with limited participants. And to somebody else's point about reimbursement, that we really feel that, existing staff and volunteer infrastructure in senior centers, public housing can really support continuing to implement Stay Connected in these settings. We, of course, have to be very educated on, how these programs can be sustained, without funding from NIMH or the city and or places like that. All right, so totally open for other questions or observations that you all may have.
So I have a comment that this was very interesting, Patrick, and just again a reminder, the very last link that I've posted here goes to where you can see the handout, and at the end of the slide handout, which has some amazing information and resources in it, is also the manual that he was talking about. So that's in the PDF as well. Any questions, overview types of questions, or even comments about experiences you've had working with older adults, where this may be helpful, or challenges that a program like this should probably address? Cindy said, was there any contact with participants' families?
I don't believe so. I don't remember hearing reports about that. We tried to frame this as a one-on-one kind of intervention. I think if family were to be involved, I think it would be from the, it would have to involve patient permission, and it would have to be from the perspective of, this is a program that your relative is participating in, and these are the kinds of things that we're working on together. If she finds it helpful to let you know more specifics and how you can support some of her goals and action plans, then that would be great. But we wouldn't have formal family sessions beyond that.
I could see encouraging connections with family, encouraging the older adult to have connections with family would be important.
That's right, yeah.
Cindy says the families could be trained in behavioral activation, although I see it's not in your study, but maybe that's something to think about in the future.
There's some challenges there, but there could be some
Yeah.
value. Yeah. Well, actually, I'm reflecting on some of the literature on behavioral activation, more the formal psychotherapy, particularly as used in Latinx communities, there is more of an emphasis on kind of involving the whole family and helping the whole family kind of function and set goals kind of together. So there's certainly room to be creative that way, depending on the client or patient's preferences and ideas.
Other questions or comments? Just going to post these links again. Well, thank you so much, Patrick. This was really helpful. Just so many things to, I guess, kind of unpack from this program and some thoughts. I really appreciate you sharing the resources with all of us. And I would point out that his contact information is listed at the top of this slide if you have additional questions or thoughts or want to hear how the research is progressing or when the publication will be coming out.
Yeah.
That sort of thing.
Yeah. And do feel free to email me. I'll also note that in my role heading up behavioral interventions at the Ames Center here at the University of Washington, we offer a lot of trainings, particularly for primary care, both clinicians and staff, and not stay connected per se, but in other evidence-based interventions for depression, like problem-solving treatment, behavioral activation. And this last link is that we are offering a series of free webinars. I think it's restricted to only Washington State providers on geriatric mental health issues. So feel free to check that out too. Free, and if I didn't mention, for CE credits.
Oh, great. Yeah, we're always interested in free CEs.
Yes, yes.
All right, so thank you very, very much. We'll see you, all of you, next week. And Dr. Raue, this has just been really helpful. So I appreciate your taking the time to share this program with us.
Absolutely.